This is Sean Grady from the Department of Neurosurgery at the University of Pennsylvania, and this is an overview of the chapter on initial resuscitation, pre-hospital care, and emergency room care in patients with traumatic brain injury. Key concepts from this chapter include understanding that secondary insult is a physiologic derangement that affects outcome, that the primary survey of airway, breathing, and circulation can be performed simultaneously rather than in sequence, that CT scan of the head is the gold standard for imaging for moderate and severe traumatic brain injury, that biomarkers recently have been identified that may reduce the need for CT scan in mild traumatic brain injury. Recent research in multimodality monitoring and brain oxygenation seem to be able to improve outcome in patients with severe head injury, though this remains to be fully tested. Keppra is now the prophylactic anticonvulsant of choice, as opposed to dilantin or fosphenytoin. And finally, transfer of moderate and severe traumatic brain injury to level 1 and level 2 trauma centers improves outcome. The guidelines for pre-hospital management of traumatic brain injury include the measurement of oxygenation and blood pressure, determining the Glasgow Coma score, and analyzing brainstem reflexes, and in particular the pupillary examination. On the treatment component, ensuring that the airway is secured, that the patient is properly ventilated, and receiving sufficient oxygenation is critical. The fluid resuscitation is essential to avoid hypotension, and then identification and treatment of findings that are causing cerebral herniation. The primary survey consists of 5 components: airway, breathing, circulation, disability, which is the measurement of the Glasgow Coma score and determining brainstem reflexes, and exposure, which is removing garments that may mask injuries that the patient has in his extremities or elsewhere. The airway, breathing, and circulation component can be performed simultaneously without concern that this will lead to an adverse outcome compared to being performed in. Once the primary survey is complete, the physician moves to the secondary survey and neurological assessment. The secondary survey consists of 5 elements, which can be summarized as AMPLE, meaning allergies, medications, past medical history including pregnancy, last meal, and the events that led to the trauma. Close attention should be paid to the anticoagulant history, given the number of individuals who now are taking anticoagulant medication, particularly in individuals over the age of 65. The detailed neurological examination includes, if possible, specific motor grading of the muscles of the extremities, a sensory examination, and reflexes. This is critical for the evaluation of individuals with spinal cord injury. It is essential to obtain a Glasgow Coma scale score on patients with brain injury. This is because the score is quite reproducible between examiners and over time, so that a patient can be observed, and if he or she deteriorates, it is easily detected. The score is broken into 3 components: an eye score, a motor score, and a verbal score. There are circumstances when the eye score and the verbal score cannot be obtained, for example, in the case of intubation or in the case of facial trauma. Motor score is quite reliable in predicting the overall Glasgow Coma score. In the event of significant injury, a painful stimulus is often required in order to obtain a response. That painful stimulus can be administered through nail bed pressure, a sternal rub, or trapezius pinch. It is important to be mindful that the patient may also have a spinal cord injury that may render him insate below the level of the cervical spine. The Glasgow Coma score is then added up, and this provides a way to divide the brain injuries into 3 categories of mild, moderate, and severe. severe being 3 through 8, moderate being 9 through 12, and mild being 13 through 15. Once the primary and secondary survey have been accomplished, the next step is to move to imaging. Once the primary and secondary survey are complete, the next step of the treatment of the patient moves to imaging. CT scan is the modality of choice and is a required study for patients with GCS 3 through 12. Skull radiographs have become much less important since the advent of CT scan over 30 years ago. MRI scan can be very helpful in identifying more subtle injuries such as diffuse axonal injury, but is generally much less able to be accomplished in an emergency setting, unlike CT scan. Cerebral angiography may play some role, but presently CT angiogram is a much easier modality and can be obtained also in the emergency room setting. Finally, CT scan of the cervical spine is often part of the routine protocol as opposed to ordering cervical spine x-rays. There has been substantial interest in the role of CT scan for patients with mild traumatic brain injury. A series of guidelines have been established in those patients who have had loss of consciousness and have a GCS 13 through 15, those individuals who have headache, vomiting, older than age 60, drug or alcohol intoxication, short-term memory deficits, physical evidence of trauma above the clavicle, a post-traumatic seizure, a GCS of less than 15, a focal neurologic deficit, or coagulopathy should receive a CT scan. CT scan for mild traumatic brain injury when there has been no loss of consciousness or post-traumatic amnesia may be considered for individuals who have a severe headache or vomiting, have an age over 65 years old, the physical signs of a basilar skull fracture, such as blood behind the ears or around the eyes, a so-called raccoon sign, a Glasgow Coma score of less than 15, a focal neurologic deficit, or coagulopathy in particular patients who are on anticoagulant medication. The initial management of patients with moderate and severe traumatic brain injury focus on avoidance of hypoxia and hypotension, as well as control of intracranial pressure. Placement of an ICP monitor is illustrated in the accompanying video. In a study performed by Chestnut and published in 1993, the effects of hypoxia and hypotension can be clearly seen. In this group of patients with severe traumatic brain injury, if the individual had neither hypoxia nor hypotension, their chance of a favorable outcome was 51% and chance of death 27%. On the other hand, if both hypoxia and hypotension were present on the initial evaluation of the patient, the chance of a favorable outcome was only 6%, whereas the chance of death was 75%. The evaluation and treatment of mild traumatic brain injury is more complicated. This is because many times patients are at GCS 15 and it's unclear whether they actually had a brain injury or not. In this series of guidelines published in 2008, any individual who has a period of observed or self-reported transient confusion or disorientation or impaired consciousness, or has a period of observed or self-reported dysfunction of memory, such as amnesia, around the time of injury, or has observed signs of neurological or neuropsychological confusion, dysfunction such as confusion or difficulty with balance, can be considered to have a mild traumatic brain injury, even with a GCS of 15. In this final algorithm that summarizes the chapter, the initial evaluation of the trauma patient starts with the primary survey, includes an abdominal sonogram for abdominal trauma, involves the evaluation of the metabolic state, which is all part of the secondary survey. If that physical examination demonstrates scalp lacerations, depressed skull fractures, spinal fluid from the nose or ears, raccoon signs, or battle sign, a CT scan is indicated. If the neurological examination shows a moderate or severe traumatic brain injury, or if the mild traumatic brain injury has one or more of the following, such as headache, vomiting, over the age of 60, a CT scan is indicated. More recently, the introduction of biomarkers such as S100 beta or GFP have been utilized to screen out patients who do not need CT scan. These are only elevated in cases where there is identifiable blood on the CT scan, and so if they are not elevated, a CT scan can be considered optional. Once the CT head is performed, this is the key element for dividing out the next series of treatments, including treatments of subdural hematoma, epidural hematoma, depressed skull fractures, and so forth, all requiring neurosurgical intervention. If, on the other hand, the CT scan is normal, and yet the patient's neurological function is still significantly abnormal, an MRI scan be considered to determine diffuse axonal injury or edema. If these are present, medical management is the primary approach. If there is substantial cerebral edema, this may be a sign of high elevated intracranial pressure where ICP monitoring is then necessary.